Good afternoon, everyone. I thank Dr. Ashish Singh for giving me this opportunity. I'm Dr. Suhas Masilmani from Sunshine Hospital, Hyderabad. There's little similarity between my talk and Dr. Adarsh's talk, but the takeaways are similar, but the way we are reaching that is different. So the way I approach this talk is, why did I shift to robotics? What is in it for the surgeon, and what is in it for the patients in general? For the surgeon, for me, there is a comfort of ability to pre-plan the surgery well. Number two is better control in my surgery. I'm able to predict my surgery well. I know what the gaps are. I know how I can take the cuts. And I know the end result in sight even before I do the surgery. Next is less work in terms of soft tissue releases. There is accuracy and precision. Both are different. Accuracy is trying to reach the right target. Precision is reaching that target every single time. So there is a difference there. And now we've embarked on this journey of personalized arthroplasty, which is an interplay between alignment strategies as well as the balance strategy. And in our center, because of the number of surgeries we do, we have 15 fellows. So we've used this as a research tool as well as a teaching tool for our patients. I won't belabor more on the patient benefits. We'll show you some case examples as how we have less pain, better rehabilitation. And there is early data coming out from the Australian registry showing even the revision rate, there is difference between conventional surgery versus robotics. So this is a case example of a patient who has a malunited tibia down below. So in complex cases as well as simple cases, you have the ability to plan your surgery. You know the size of the femur as well as the tibia. You will know where the bone loss is. You can actually measure it, and you can decide whether you need to actually plan for screws or bone graft, so on and so forth. So in these patients, we can also decide whether to use a stem extension. And so this is the part where I was telling you about the ability to pre-plan these patients. The second big advantage is shape matching the femur. We've already shown you this. This is the first time you can actually recreate the posterior condylar offset. And there is a big deal of work being done on not anteriorly stuffing the patella. And here you can clearly see that because of the robot, we are able to make sure that there is no anterior stuffing and preventing patellofemoral complications. So the main difference between robotic surgery versus conventional surgery is, in conventional surgery, we all start with the cuts, right? Once we do the cuts, then we assess the balance, and then we go on, do the releases in order to balance that knee. But in robot, it is flipped. First, you open the joint, you first assess your balance, and then we go through a process of manipulating the position of the implant so that we balance the knee first and then go ahead and cut. So the big difference is, in conventional surgery, you cut, then you balance. In robotic, you actually first balance and then you cut. So this is where you can actually see I'm stressing the joint intraoperative, and you can see I'm able to capture the extension gap. Once I'm done that, then I move ahead and capture the flexion gap. So now the whole game of manipulating the implant is getting these numbers to equal. This is a case example of the right knee where you can see initially these are the gaps 23-20, 22-20. By just giving 2 degrees varus in the femur, in the tibia, 1 degree varus in the femur, and giving 2 millimeters of elevation on the tibia, I'm able to get these numbers down to 18 even before I made the cuts. So this is known as dynamic joint balancing, and I'm doing this without any soft tissue release. Similarly, this is a little more complex knee where you can see the numbers. This is a left knee. It is much tighter. And you can see I've given 3 degrees varus in the tibia, 1 in the femur, then adjusting for the in the coronal plane, sagittal plane, and then giving 3 degrees of external rotation. So all this is done within the boundaries of functional alignment, which is defined well laid out by the FDA rules. So once this is done, the accuracy of the robot comes in, where whatever plan you have decided, you can execute it with hardly any issues. So that is the precision part of it. And then doing it with very little damage to the soft tissues. So we've done a study where we took 100 patients, equal deformity. We did mechanical on one side, functional on the other. And we've clearly shown that before soft tissue releases, functional alignment could balance 60% of the knees versus mechanical alignment, which could only balance 32%. So in green are the soft tissue releases we had to do in conventional surgery versus the blue, which is robotic surgery. So in a nutshell, in that particular study, we have shown that for the same amount of deformity, you need to do twice the number of releases if you're doing a mechanical alignment versus functional alignment, which is in terms of robot. And the other question that keeps being asked to us is, what is the difference between navigation as well as robotic? Navigation is only a planning tool. It will only tell you the sense of direction. For example, if I have to go from Hyderabad to Patna, if I take a manual map and embark on that journey on my own, there are chances that I will commit errors. But on the other hand, if you have a turn-by-turn navigation, which will tell you exactly how to reach Patna, then I have a better chance of reaching with less amount of error. This is what I was trying to tell you about accuracy versus precision, right? You're highly precise, but in manual surgery, because of mechanical alignment, there is a chance that the target is not right. But in personalized alignment, trying to recreate the phenotype, there is a better chance that you're both accurate as well as highly precise. Now is the era of phenotype classifications. This is CPAC classification, very well published by Dr. McDessie. We in India were the first ones to embark on this journey. For example, if you look at this particular picture, you can see all these 5 knees are varus, but each of them have a different phenotype. For us, now we are actually doing long leg films, trying to make sure that we match phenotypes in all these patients and to recreate these phenotypes. There are multiple alignment strategies. I don't want to go into these details, but all of these we are practicing in our center, and we are able to do randomized control trials comparing one with the other to see which is doing better in our patients. Similarly, gross deformities, we've already published. The other important feature was everybody would ask, is it relevant for gross deformity corrections? So we've shown in multiple studies as well as case examples that we are able to operate on these patients and give a very good results. This is again a patient with severe bone loss in whom we were able to use the robot and give a good result. This is again a side swipe deformity in which robot was used. So in patients, again, this data was already there. For us, it is what we see in our patients, right? This is somebody on day 1 who's able to do complete SLRT, and he's able to even flex the knee up till 90 degrees without any pain. So we attribute this to the less soft tissue release that we're doing in our patients. These are some of my patients who are at 1 month post-operative. The confidence and the ability with which their walking is better. Even conventional surgery, this can be achieved, but the consistency with which we are able to do this in our patients is much better in robotic as compared to manual. This is an IPS officer who came from Delhi who got operated, and this is him at 3 months, where he sent me a picture. And some patients even surprise us. This is a lady who I did bilateral, and she's able to sit and squat. Why? I don't have an answer. Maybe it's the alignment strategy and the balance that worked perfectly for her. So this is where we are trying to do more research and see who adapts well to which. And this is another hip patient who is able to do, this is 1 month post-op just before his wedding. He went into the surgery. Just 1 more minute. So this is the data I was talking to you about. So if you see here, the one in green is Mako, and the one in red is conventional surgery. So at the end of 5 years, this is the first time Australian Joint Registry has started showing a difference in revision rate between conventional surgery versus robotic. This is another excellent graph. Even in triathlon, conventionally done triathlon versus robotic triathlon, again they're showing that there is a difference in revision rate. So this is early data. We're using it as a research tool. There's been mention of AI, so I won't belabor the point. So the take-home message is, for me as a surgeon, it gives me better control on surgery. It makes me precise every single time, irrespective of my dexterity. I'm able to achieve the result. And as time progresses, as we understand more about phenotypes, and we are able to match those phenotypes to the soft tissue balancing, I'm sure that we will be able to give good results consistently in every single patient. Thank you.